Okay, so welcome to the channel, and today we are going to see Young Tutor's view on fetal circulation. You know, there are differences between how blood flows in adults and in a fetus. So today we are going to see how blood flows in a fetus during the intrauterine life. So stay tuned as we see the Young Tutor's view on the fetal circulation. Okay, so let's start from the placenta. This is the placenta, and in the placenta what we have the intervillar spaces. So those intervillar spaces that you can see divided into compartments by the placental septa. These compartments are 1, 2, 3, 4, 5 in this diagram, just to show you how they are separated by this the placental septa, which are containing those blue vessels that are called the endometrial veins. So these intervillar spaces are going to be filled with maternal blood by the maternal arteries. So those maternal arteries are pouring blood in the intervillar spaces through those small tortoise arteries that are called spiral arteries. So spiral arteries are those in red in a curvy manner. So those are spiral arteries that are pouring blood in the intervillar spaces from the maternal arteries. So blood is poured in the intervillar spaces for gaseous exchange and diffusion of nutrients from maternal blood into fetal blood. So how are these spaces drained, like after gaseous exchange and diffusion of nutrients? We have maternal veins. So maternal veins are the ones that are draining these intervillar spaces through the endometrial veins, these veins that are extending into the placental septa, as you can see here, those in blue extending into the placental septa. Those are endometrial veins that are draining blood from the intervillar spaces to deliver it to the maternal vein so that it can get back for oxygenation. So now this is the maternal side. Let's go to the fetal side. To the fetal side, what we see is this artery here, the umbilical artery. So those umbilical arteries, they are usually two from their origin. So we can see that blood, fetal blood, which is less in oxygen and nutrients, is coming via the umbilical cord or via the umbilical arteries to reach the placenta. So from here we can see these arteries bifurcating, and then they are dividing into small arteries that are called that are called chorionic arteries. So chorionic arteries are extending into the chorionic villi. You can see over here you can see those chorionic vessels, the arteries, chorionic arteries and the chorionic veins covered in a white coat. So that white coat is what is called the chorionic villi. So what we have are these chorionic vessels extending into the chorionic villi for gaseous exchange. What we know, or what we should know, is that this fetal blood has got more hemoglobin that is going to actively trap oxygen from the maternal blood so that the fetal blood can become oxygenated. And the other thing is that this fetal blood has less nutrients compared to the maternal blood. So nutrients are going to diffuse from the maternal blood to the fetal blood because of that difference in concentration of the nutrients. So what is going to happen when this fetal blood now gets oxygenated and it has nutrients? We have the umbilical vein now. The umbilical vein is what we are going to have. The umbilical vein via the chorionic veins is going to kind of like take blood that is oxygenated and then deliver it to the fetus now. So we have this umbilical vein here that will deliver that blood which is oxygenated and has nutrients now to the fetus. So the placenta has those two umbilical arteries that are entering it, and this vein, the umbilical vein that is leaving it to deliver oxygenated blood to the fetus, these are ensheathed in the umbilical cord. So what we see here is the umbilical cord reaching the fetus, and the umbilical vein is going to reach on the fetal liver first. So the fetal liver here is going to have the common portal vein and the right portal vein, even the left portal vein. So in this view, we are interested in the left portal vein because the umbilical vein is seen to extend into the left portal vein. So as we can see there, this umbilical vein and the oxygenated blood, which is full of nutrients that it carries, they reach the left portal vein. Now what we see here is that this liver here has so much resistance. It resists blood. Like the liver sinusoids resist blood because the liver is not yet mature. So what we see from here is that only 20 to 30%, that is 20 to 30% of blood that is reaching the left portal vein is going to enter the liver just for the maturation of this liver, the growth and maturation of it. But most of the blood, because of resistance of the liver sinusoids, is going to find an alternative pathway to reach the systemic circulation in the IVC. So most of the blood, like 70 to 80% of blood, will find an alternative pathway through the ductus venosus. So this ductus venosus is an alternative pathway for blood to flow from the left portal vein into the ductus venosus because of the resistance of the liver sinusoids. So this ductus venosus is also called the first circulatory shunt because it is diverging blood so that the liver or portal circulation can be bypassed because the liver is not yet mature. So we can see that ductus venosus joining to the IVC, the inferior vena cava, so that the blood which is oxygenated and containing nutrients can enter into systematic circulation through the IVC and be transported to the left, to the right atrium in the heart. Yeah. Blood is reaching the right atrium through the inferior vena cava here, and what we can observe here is that blood in the right atrium is not just coming from the inferior vena cava, but it also enters through the superior vena cava from the head and neck. So the blood in the right atrium here is going to come both from the inferior vena cava and the superior vena cava, and then when it reaches the right atrium, it has two possible pathways. So this valve here is functional, the tricuspid valve, the right tricuspid valve here, it is functional. So it is going to accept some blood here to allow flow of blood here. But again, blood that flows, understand that the right side of the heart is responsible for pulmonary circulation, specifically the right ventricle. So that one is for pulmonary circulation, and pulmonary circulation in the fetus is not yet functional because the alveoli are fluid filled instead of being air filled. So what do we see when blood is about to flow here? So blood that is about to flow here, only 20 to 30% of blood will flow through the tricuspid valve here, the right tricuspid valve, because it's functional. So 20 to 30% will flow in this right ventricle. Now the remaining 70 to 80% of blood will find an alternative pathway through what we call the foramen ovale that is there. So the foramen ovale is what is called the second circulatory shunt that is diverging the blood that is resisted by the pulmonary circulation, so that this blood can at least flow to the left side of the heart and find itself in the systematic circulation. So now this foramen ovale consists of the septum primum, that one there, and it also contains, this septum primum contains a hole over here. This hole over here is called the ostium secundum. Ostium secundum. So another thing that this foramen ovale contains is the septum secundum. Septum secundum over there. So an important MCQ question here, listen carefully, on the foramen ovale is the question of where the ostium secundum is. So the ostium secundum, as you can see, it is on the septum primum, not on the septum secundum. No. So it is the ostium secundum is an opening in the septum primum. So now what we see over here is that 70% to 80% of blood that reaches the right atrium will flow to the left atrium through the foramen ovale. But now we have said that we have 20 to 30% that is of blood that is flowing to the right ventricle. So that blood will be pumped through this valve here, the so-called semilana valve or pulmonary semilana valve. This valve, through this valve, blood will be pumped from the right ventricle into the pulmonary trunk that is here. So now, since we have no pulmonary circulation working, so blood that flows through the pulmonary trunk finds an alternative pathway through a duct that we call the ductus arteriosus. So that duct there connects the pulmonary trunk to the descending thoracic aorta, so that this blood, which is resisted by the pulmonary circulation, which is not yet into function, can reach the systematic circulation. So blood in the pulmonary trunk is reaching systematic circulation through the ductus arteriosus. So it is flowing from the pulmonary trunk into the descending thoracic aorta and enters systematic circulation. So that is what we can see from here, that the ductus arteriosus, being also called the third circulatory shunt, to bypass blood, to bypass the pulmonary circulation which is not yet functioning, so that blood can flow from the pulmonary trunk direct into the descending thoracic aorta. Yeah. So now the question that you're going to have is that now, since blood is not flowing through the pulmonary arteries, rather it is flowing direct into the descending thoracic aorta, how are the lungs going to grow and mature? Because they need oxygen, they need nutrients in order to grow. So what we can see from here is that these lungs are going to be supplied with oxygen and nutrients by the bronchial arteries. So bronchial arteries are the ones that are going to supply the blood. So the bronchial arteries only accepts 8 to 10% of the blood that flows in the descending thoracic aorta, because I have said that there is vasoconstriction, what we call hypoxic vasoconstriction. Like the vessels in the lungs are constricted. Why? Because of low levels of oxygen. Yeah. So what we see from here is that only 8 to 10% of the blood in the descending thoracic aorta is going to flow into the lungs to provide nutrients and oxygen needed for the maturation of these lungs here. So now let's see what is happening to the blood that is flowing through the descending thoracic aorta. So what we have here, this is the fetus having this descending aorta. So this descending aorta at the level of L4 produces, or rather terminates by bifurcating into the common iliac arteries. So the common iliac arteries also bifurcate, as we can see here. They bifurcate to form this one, the external iliac artery, and this one is the internal iliac artery. So the internal iliac artery is the one that we are interested in, because the internal iliac artery gives the posterior branches, or the posterior trunk and the anterior trunk. So the anterior trunk of the internal iliac artery is what is going to give the branches that are going to join the placenta. So now we can see here that these umbilical arteries that we discussed earlier, they are going to come from the internal iliac arteries. So the internal iliac arteries anterior division branches are going to come from there and join to the placenta. Those are umbilical arteries, so that this blood, fetal blood, can flow to the placenta and come into close proximity with maternal blood, so that this blood can be more oxygenated and receive nutrients again. So after this, now the process is going to continue like that, because when fetal blood less oxygen and nutrients flows back to the placenta, it will follow that the those arteries that I talked about, the chorionic arteries, are going to deliver blood close, or pouring it in the chorionic villi, so that gaseous exchange can happen in those intervillar spaces. Yeah, so this process just happens again and again. Yeah, that is how fetal circulation occurs. Okay, so what is the fate of these circulatory shuns after birth, or what are they going to become in neonates, like after birth, according to Young Tutor's view? So let's get into it and see what they're going to become. So what we know is that after birth, what happens is that there is expulsion of the placenta. So placenta expulsion, what follows is just the clamping of the umbilical cord. So when the umbilical cord is clamped and cut, these umbilical vessels will just remain connecting to the umbilicus. So when they are connected there, what happens is that their supply is lessened. Especially for the umbilical vein, the supply just stops because it was receiving blood from the placenta. Now the placenta has been the placenta is not there anymore, because the umbilical cord has been clamped and cut. Yeah, so what happens to the umbilical vein then, because of low supply, because of the ceased supply, let me call it so, because it's not receiving any blood right now after birth. So the umbilical vein is going to lose its fibrinogen because of that lack of supply of oxygen to it. It will lose its fibrinogen, and then the fibrinogen will be replaced now by what? To be replaced by collagen and other fibrous tissues, so that the umbilical vein here can now become a ligament. So it will become what we call the ligamentum teres. So the ligamentum teres, or change of the structure of the umbilical vein completely, to become the ligamentum teres is within just 1 to 2 weeks after birth. So what will happen to the umbilical arteries? Umbilical arteries still receive some amount of blood. Of course, it will have low supply, but because blood is still flowing through the internal iliac arteries, so it will have some blood flowing into them, but that low supply of blood into the umbilical arteries will also cause them to start losing fibrinogen slow but sure, and then the fibrinogen will be replaced by collagen and other fibrous tissues in order to make the umbilical arteries become ligaments. So this process actually takes some time. It can take 2 to 3 months for the umbilical arteries just to change their structure from vessels to ligaments. So what will happen is that on the proximal aspect, like where they are originating from, the internal iliac arteries, where they are originating from, these umbilical arteries will give branches to the urinary bladder. Those branches are called the superior vesical arteries that supply the superior aspect of the blood. So the proximal aspect of the umbilical arteries will become superior vesical arteries. Yeah. And then what will happen to the distal aspect where they are continuing to connect to the umbilicus? What happens is that that distal portion is going to lose its fibrinogen, and the fibrinogen, of course, replaced by the collagen and other fibrous tissues, so that the distal portion can form the medial umbilical ligaments. Yeah, so the process, I said, it takes longer in these because of low supply or some supply from the internal iliac arteries, the anterior branch. So it will take 2 to 3 months for the umbilical arteries to completely change from being vessels and being medial umbilical ligaments. So what we have again here is the ductus venosus. The ductus venosus is no longer receiving blood from the umbilical vein. So blood flow has changed. Now the portal vein is the one that is supplying now the common portal vein, this one. So blood that is flowing through the left portal vein will be mainly from the common, this one, the common portal vein. So what happens is that because of that low supply of blood to the ductus venosus, it will also begin to lose its fibrinogen. It will lose also its prostaglandins. So as it loses the prostaglandins and fibrinogen due to low supply of oxygen to it, it will also start becoming a ligament. So that process or closing of the ductus venosus will just take like some minutes to hours, and then but the structural change for it to cease being a vessel and becoming a ligament will take 1 to 2 weeks, just as the umbilical vein took 1 to 2 weeks to become the ligamentum teres. So we will have the ductus venosus becoming what we call the ligamentum venosum just within 1 to 2 weeks, because its work of diverging blood has ceased. So what is going to happen when it remains open, like, it doesn't close? So if this vessel, the ductus venosus, does not close within that specified time, we are going to see that that vessel is going to be abnormally shunting blood from the left portal vein into the IVC. That will lead to so many conditions, because that blood, it will affect the ability of the liver to detoxificate that blood, because the blood that is reaching the liver or the portal circulation, it is supposed to to undergo detoxification so that those harmful substances, toxins like ammonia, can be filtered out by the liver before blood goes into the systematic circulation. So when this remains open, the ductus venosus, when it remains open, what we are going to see is that it's going to be abnormally shunting blood or diverging blood before it is processed in the liver. It will diverge it. It will bypass the portal circulation, and the blood will find itself in the IVC unprocessed. You see, so those toxins that have gone there without being processed or filtered out will cause abnormalities in the functioning of the body. Okay, so let's now see what is going to happen to the foramen ovale. The foramen ovale is this one. We know that in neonates now, neonates have started breathing. So as they breathe and cry, you know, air is going to be flowing to the lungs, and the alveoli now have more oxygen. So that increase in the oxygen levels in the alveoli will cause vasodilation in the capillaries that are surrounding those alveoli. So what will happen is that as vasodilation happens, these pulmonary arteries here dilate, and even pulmonary capillaries there dilate. We are going to have low pressure in the pulmonary circulation. So what is going to happen is that more blood will be received now by the left atrium here, because as the pulmonary veins are bringing more blood now from the lungs, we're going to have more blood in the left atrium that is pushed through this bicuspid valve into the left ventricle, and then this blood here in the left ventricle be pumped through this aortic valve into the ascending aorta. So the increased pressure in the ascending aorta will be pushing what we are calling the septum primum of the foramen ovale towards the septum secundum of the foramen ovale. So these two are going to come together here. So those two will come together, and then as they come together, they are going to be covered by fibrin. So that fibrin covering these two will lead to the closure of this gap here called the foramen ovale. So it will now become what we call the fossa ovalis. Yeah, the process will take 3 months to a year. Yeah, it's a slow process, and sometimes this process cannot be that successful. It can leave a small gap here called the patent foramen ovale. So the patent foramen ovale, it can be asymptomatic. The reason is simple, because this right atrium has low pressure, and then this gap is also small, so it will be there, but blood won't be passed to the left atrium because it is small and pressure is low here in the right atrium. But now the problem comes in when you have problems with your pulmonary system, where you have those conditions that will cause you to cough so much or sneeze too much. So blood here will be at high pressure because you are sneezing and coughing. You have pulmonary hypertension, so blood will be forced into this hole. Venous blood will be forced here, though the hole is small. So as blood passes without being filtered by the lung, you know that venous blood has got those that we call venous clots. So those venous clots, because the lungs or pulmonary circulation has been bypassed, paradoxically, what we call paradoxial embolism, the clots, those venous clots, will find themselves in the right or on the left atrium, and then that venous blood together with blood received by the left atrium will be pumped in the left ventricle. Then it will make those clots to go to the systemic circulation without being filtered. So those venous clots that have reached in the systematic circulation can ascend up via the common carotid arteries, and then as that blood with venous clots reaches the brain, it's going to cause lodging there. When the vessels of the brain are lodged with those venous clots, what are we going to have? We are going to have what we call ischemic stroke. So there is increased risk of stroke when you have a patent foraminal valley and then you have pulmonary issues. So what will happen? What will happen is that we are going to close that gap. Right? I've talked about paradoxial embolism already. We are going to close that gap through what we call a catheter-based device, so that you don't have that stroke, ischemic stroke. Yeah. So let's go to the ductus arteriosus now. So the ductus arteriosus, that one also closes because pressure in the pulmonary trunk has reduced, and blood now is preferably passing through the pulmonary arteries rather than the ductus arteriosus. So that reduced supply to the ductus arteriosus will make its tissue losing fibrinogen replaced by collagen and other fibrous tissues, making this one become a ligament that we call ligamentum arteriosum. So that process just takes place in 2 to 3 weeks after birth. So what happens when it doesn't close? Because we know that now pressure is high in the descending aorta, so blood won't flow from the pulmonary trunk to the descending aorta. Here we have low pressure, high pressure there, so blood will flow backward, what we call the left to right shunting. Yeah, so blood will flow from will be flowing from the descending aorta into the pulmonary trunk when this ductus arteriosus does not close. So what is going to happen, because blood now is flowing from the descending aorta to the pulmonary trunk, that blood will flow now into the pulmonary arteries, and pulmonary circulation will have a overload. So it will lead to what we call pulmonary overcirculation, because blood will become too much here. Some blood passing through this when it is patent, and blood that is received through the pulmonary trunk. So all that will make the pulmonary circulation to be overloaded. So we'll have pulmonary overcirculation over here. It will affect the functioning of the lungs. And then how are we going to have heart failure through that? Because you know the blood that is returning to the heart is receiving blood rapidly from the pulmonary veins here, from the lungs, because of this duct here, yeah, which is patent. So the heart will be pumping blood rapidly here and there within short periods. So the heart will be overworked to lead to heart failure there. Yeah, so we can have heart failure from that. Okay, so thank you so much for your attention. That was Young Tutor's view on fetal circulation. So if this content is useful, remember to like, share and subscribe to this channel for more upcoming videos. For now, bye bye, until next time in the Young Tutor's view.